Okay, welcome back, everybody. I am very sad to announce that this is our last ECHO session together. I have to say that I have really learned a tremendous amount from all of you, and I'm very grateful, so thank you for that. And with that, I will introduce Christine Shepard. Really excited to hear from Christine today. She's a researcher at, and I guess a social worker and PhD by background at Sunnybrook at St. John's, and very excited to have you speak with us today. So with that, I'm going to mute myself and turn it over to you, Christine.
Thank you. Thanks so much for everyone for being here. So today we're going to be talking about isolation and loneliness. And these are things that I'm sure we have all come across in our practice, but with the COVID-19 pandemic, they've really come to the forefront of a lot of conversations, with many people talking about the pandemic as a pandemic of loneliness. I have nothing that I need to disclose today. So for today, our learning objectives are really to dive into social isolation and loneliness and try to define these concepts and explore how they are similar but totally different concepts from one another. We are going to identify some of the risk factors and health outcomes associated with experiencing isolation and loneliness. And at the end, we're going to have an opportunity to reflect on what we do in our own practice to assess and promote social well-being among our clients. Humans are immensely social creatures. We are designed to thrive in families. We're designed to form interpersonal connections with other people and to build these communities and participate actively in the communities we create. And these social bonds are immensely good for us, and they're really good for our well-being. People who have strong social connections are less likely to become ill. And if they do become ill, they will typically recover faster. But perhaps the most compelling argument for having good social bonds is that we actually die sooner without them. Now, one of the strongest arguments that I have heard around this idea that a lack of social bonds is a really important public health risk came out in 2010 when a group of researchers did a meta-analysis on 148 studies that followed over 300,000 people for 7.5 years. And they concluded that individuals with adequate social relationships have a 50% greater likelihood of survival compared to those with poor or insufficient social relationships. And what was really interesting in their findings is that the magnitude of this effect was comparable with quitting smoking. And they found that it exceeded many other well-known risk factors for mortality, such as being obese or having low physical activity levels. And so this was one of these sort of groundbreaking articles that really built a strong argument for including a lack of social bonds as a public health risk that public health people and practitioners and policymakers need to be paying attention to. So I wanted to start off with a mentee in the beginning around what we think we hear of when we hear the phrase insufficient or poor social relationships. What is coming to mind when you hear that phrase? Seeing some great answers coming up here. People are saying things like loneliness, solitude, having a lack of family support, a safety risk, which is an excellent idea, isolated, not having family, not having meaningful relationships. So poor, insufficient relationships could be ones that lack meaning to you. Being disconnected, a lack of purpose, friendless. So there was a recent Toronto Star article about a month ago that was published, and they did an interview with an older woman who lived in long-term care, and she described her experiences of poor and insufficient social relationships. And she described them as like a pain in my heart. I have no human contact. The PSWs do come in and bring my food and tea or coffee, but they are so busy and have so many residents to deal with that they don't have time to chat with me. I understand, but on the other end, I feel bad. And so these poor or insufficient social relationships lead to situations where people experience isolation and loneliness. Social isolation is an objective picture of your social health. It objectively takes stock of your social network. And people who are isolated typically have very small social networks. They lack a lot of social relationships, and the ones that they do have are likely very poor in quality. Social isolation can also be reflected in cases where people don't participate in a lot of meaningful social activities with friends or other people in the community. Loneliness, on the other hand, is your subjective experience of your social isolation. And it's usually reflected as a discrepancy between the quantity and quality of relationships that you have versus what you want. So it's usually people are wanting more relationships, they want better quality relationships than what they currently have available to them in their social network. And when you're taking stock of isolation and loneliness and thinking about how you might assess it or measure it or conceptualize it, there's a couple of different dimensions of your social network that you can think about. You can think about the structure of your social network. So that's who you have relationships with. What types of social activities do you participate in? What types of organizations do you engage with? And how frequently do you do these things? How often do you see your friends? How often do you call your grandma? How often do you play cribbage with your friends? Those types of things. The function gets at what types of support is available to you in the relationships that you have with people. Is it an instrumental relationship? Is it one that provides a lot of emotional support or perhaps financial support? And when you're examining the function, you can also think about how the resources flow within or between your network. So is it a mutual relationship where resources are flowing back and forth, or is it more of a one-sided relationship where you're providing a lot of support to someone? And you can also reflect on the quality of the relationships you have in your social network. And quality can be conceptualized in a lot of different ways, but some of the key ways that people might think about quality is how satisfied are they with the quantity of relationships, with the quality of the relationships that they have with people. It could be related to availability, both actual availability as well as perceived, and if people feel that their network is available at times when they need them.
Christine, can you just define for us what you mean by an instrumental?
Yeah, so instrumental support could be some type of functional support. So instrumental activities of daily living, someone who maybe helps you get groceries, someone who might pick you up and drive you places. Transportation is a big barrier for engagement that a lot of community dwelling older adults face. So they might rely on someone to come and pick them up and take them out to medical appointments or social activities, those types of things. So those instrumental activities of daily living. It could also be
pragmatic support.
Pragmatic support. And it could be much more pragmatic too. Like you could get right down into things like meal prep and having people who help you cook healthy meals and having people who help you with your bathing and those types of things. So there's a whole sort of range of instrumental support that could be made available in a social network depending on what the needs of that person is. And that's where you can start thinking about the function of your network and whether it's adequate. Is the resources available in your network adequate to meet your needs? So a really good example is an older adult who has adult children who are very engaged. Maybe they're very connected, they call regularly, they video conference, they join medical appointments, but maybe they live 3 hours away. So they're not actually that accessible if they need help going to the grocery store, or if they need help with some sort of basic daily things. It can't be that daughter or that son that lives far away who fills that function. So those are the types of things that you can think about when you're working with older people. So if you tie these things together, what they might look like in practice, someone who's isolated will probably live alone. They will usually not leave their house very often. They might go out for really necessary or critical things, like they might go out to get some groceries, but they typically won't leave their house for recreation or social purposes. They generally have very few relatives that they would consider close. Maybe it's that they didn't have any children, or maybe it's that they don't have a positive relationship with their children. They typically won't have close contact with friends. They won't know their neighbors. They won't have close contact with their neighbors around them. And in the case of many older people, those who are very isolated may not even have access to the telephone or the internet. On the other hand, someone who's lonely, they're going to express desires for having more friends. They'll wish that they could make new friends, that they could spend more time with their friends, that they could see their family more often. They might wish that they had more opportunities to participate in more social activities, to learn new skills. And typically, if you explore their social network, you will find that they don't identify anyone in their network as being a confidant or someone that they feel they can trust. And they typically don't have someone that they feel they could rely on for help if they really needed it. So it's not so much about who is in the network, it's more about how people perceive that network and how much satisfaction and joy that network brings them. So this is a really nice figure that helps to start showing the relationship between isolation and loneliness. It's really easy to think that, well, if you're socially isolated, you therefore must be lonely, but that's not always the case. And it is certainly true that if you are isolated, you are at greater risk of experiencing loneliness. And those people who are isolated and lonely are considered the most vulnerable of the groups. They're really hard to reach. They don't have a thriving network. They're not well connected. They're not seeing health providers. They don't have people checking in on them. So they're really hard to connect with and identify. But there is some research that shows, or suggests, if you will, that these are people that are so starved for meaningful social contact that when you do identify them, they're very, very willing and active participants in social interventions. The lone farmer or the lifelong isolate is someone that is very interesting. So these are people who are isolated. They objectively have not a lot of social contacts, and maybe the social contacts that they do have are not the best quality. But they are satisfied with that. They are satisfied with that low quality and low quantity of relationships that they have. They don't find it distressing. In many cases, the lone farmer or lifelong isolate will maybe actively choose that lifestyle. They actively choose to live more alone, and that's perfectly fine. That's a perfectly valid choice that many people happily make. But there is some research to suggest that perhaps some people who are lifelong isolates haven't really freely made that choice to be that way. Some people have suggested that lifelong isolates perhaps have negative social networks. And they've had so many negative social experiences that they just lowered their expectations of their social context so that their expectations more align with what their reality is. So they've just sort of come to accept that this is what their social network is, and they've come to be okay with it. Other people have also suggested that there are sometimes external factors that negatively impact an older person's ability to participate in their network in the way that they would maybe like to. And again, they've just sort of come to accept that this is the reality, and they just take it for what it is. And so if you're working with people in a clinical context and you think that they are this lone farmer or lifelong isolate, it's worth having some conversations to really explore to what extent it was a true choice for them to have this level of isolation, and how satisfied they really are with that level of isolation, and if there are things that you can do to help better connect them so that they have a more socially connected lifestyle. The other group that's kind of interesting are the lonely in a crowd. And so these are people, by objective measures, they have very thriving social networks. They are connected, they have close friends and family, they look to have meaningful relationships, they seem to be participating in activity. So on the outside, they look very connected. But the individual actually feels quite lonely, and they feel very dissatisfied with the quantity or quality of relationships that they're having. And in places like long-term care, in places like older adult centers or community centers, where the environments are designed to be inherently social and there's sort of social networks built into the space, it can be really difficult to identify who these people are. And so I always encourage people to, take a moment back and just say, how many people in this socially dynamic environment, how many might actually be experiencing loneliness? Are there people who are lonely in the crowd here? Because if you can identify them, you can usually work with them to find different ways to help them create more meaning in their social connections, or help better align the social environment to what they would find interesting or supportive or meaningful to align with what they're looking for. So we're going to do another Menti, and I want us to reflect on our own experiences with social isolation and loneliness. I think that in order for us to work openly with clients, we need to start thinking about, have we ever experienced our own social isolation and loneliness? And maybe you experienced it a long time ago and you've been happy ever since. Maybe it's a new experience for you. This is sort of something that maybe comes and goes across people's life course. As we can see from the poll, there are a handful of people who don't experience isolation or loneliness very often, but there are just as many of us that experience it at least some of the time, or maybe even more often. And that's in line with what sort of population estimates across, in industrialized countries, about 30% of adults experience loneliness at some point in their life. So that's pretty representative of what we see in other research. So just taking stock of what isolation and loneliness looks like for community dwelling Canadian seniors, about 20% of older adults in Canada who live in the community feel that they lack companionship, they feel left out, or they feel isolated from other people. 20% report that they don't frequently do any type of social activity, and that they would like to be doing more activities that are social in nature. 25% of older adults have no close friends. And then another 28% report that they have one or two close friends, but they don't have just a broader network of friends and acquaintances that they spend time with. So no other close friends that they engage with. Data from the Canadian Longitudinal Study on Aging that recently came out in 2019 showed that about 5% of the participants were socially isolated using a composite score that they created based on things like marital status, living arrangements, how frequently you contact friends and family, retirement status, and participation in 8 different social activities that they looked at. They also found that 10% of the participants had reported loneliness or reported feeling loneliness occasionally or all of the time. So this is isolation and loneliness are things that seniors in Canada face on a regular basis. And the prevalence of loneliness in long-term care is thought to be at least twice as high as what we see in community samples. A review study found that between 22 and 42% of long-term care residents experience loneliness. A couple of other studies that I wanted to highlight from Europe showed that between 1/3 and half of residents in long-term care that don't have dementia either sometimes or often experience loneliness. One study in Norway found that 20% of their residents that they surveyed did not have any telephone contact with friends or family. And 57% had no hobbies or interests that they practiced or engaged or participated in. There are a lot of factors that increase your risk of loneliness. And I'm sure if you took a moment and reflected on the people that you're serving, the people that you see in your practice, the people that we serve in long-term care, we'll see that many of them check a lot of these boxes. People who are over the age of 80 are more likely to be isolated, as are people who have multiple physical or mental health conditions. People who have functional or cognitive impairment or who are experiencing vision or hearing loss find it more difficult to participate in their social network and are more often experiencing loneliness. Role changes and role transitions can be extremely challenging for people and put them at risk of isolation and loneliness, especially ones where it represents the loss of a social role that you once held. So in older age, these are things like retiring, maybe moving to long-term care, or the loss of a spouse. And being isolated and lonely are extremely bad for your health. They are worse for your health than smoking, than being obese, or doing no physical activity whatsoever. And a meta-analysis of 70 studies that followed 3.5 million people over 70 years reported that the risk of mortality increased by 26% for people who were isolated and 29% for people who were lonely. So being isolated and lonely is really, really bad for your health. And in addition to premature mortality, people who are isolated and lonely are more likely to fall. They are more likely to have multiple chronic health conditions. They experience rapid functional decline. Their sleep is disrupted, leading to multiple other secondary outcomes associated with that lack of sleep. People who are lonely and isolated have poor mental health outcomes. They're more likely to report depression. They experience reduced satisfaction and quality of life. They're more likely to be diagnosed with dementia. And in addition to all of these health outcome consequences of being isolated and lonely, it's also really expensive for our healthcare system. People who are isolated and lonely make more visits to the emergency department. They are more likely to be admitted into the hospital, and they're more likely to be admitted into long-term care. So now I want us to think about what we do in our practice to formally measure or assess isolation in the clients, the residents, the patients that we serve or work with. What are we doing to measure and assess isolation and loneliness? So there's a couple of people who are formally assessing isolation and loneliness, and either some of their residents that they suspect are lonely or isolated, or all of the residents, but most of us appear to not usually be assessing these things. So I did a little bit of research into this to see, like, what do we know about how frequently healthcare practitioners assess isolation and loneliness in their older patients. And what the research showed was that most of them don't formally do it. They rely on clinical judgment through conversations and other aspects of their health assessment to make decisions about whether they think that their patient is experiencing isolation or loneliness. But the research shows that healthcare practitioners are not actually very good at making that clinical judgment in this particular case. They were not very good at identifying which older patients were isolated and lonely. And they were especially bad if the patient did not live alone, or if they were actively participating in social activities. So they had an active social engagement or social environment. And so what this says is that healthcare practitioners were generally not great at identifying which patients they thought were lonely and isolated, but they were especially bad if the patient happened to be lonely in a crowd. So people who look like they should have thriving social contacts, but are still actually indeed very lonely. And one of the reasons that the practitioners cited for not generally formally assessing isolation and loneliness was because they didn't feel that they really had the tools to do it. They didn't know what to use. Now, I am not a clinical social worker. I don't have a clinical practice, but I do assess isolation and loneliness in my research. And I've come across two measures that have been designed specifically for use in older people. So they've been validated in older patients. And I like them for a couple of reasons that I think are still really important in the clinical context that I wanted to share with you today. So the first is this social network scale. It's 6 items, so it's very short. And it's actually comes from a much longer questionnaire. You'll notice that a lot of social network questionnaires are quite long and daunting because they want to get at like 100,000 aspects of your social network. And it's really not practical for a research or a clinical context, which is why I like this, because it's only 6 items. I also like it because it assesses your social network from both a family tie as well as a friendship tie perspective. So as an older person, both of those networks are really important. And as we age, both of those networks go through a lot of different changes that might make us more isolated. So friends move away, friends pass away, spouses pass away, adult children move away, adult children get busy with their lives. So there's lots of changes that happen in family and friendship networks. So it's important to explore both of those. I also like this questionnaire because it gets at both a structural, functional, and quality aspect of these relationships. So it gets at how often you see people, that's your structural piece. It gets at, could you call on them for help? So that's your functional piece. And it gets at, could you talk to them about private matters? Could one of them be a confidant for you? So that's that quality piece. The loneliness scale that I have used quite a bit in my research is the UCLA 3-item loneliness scale. And I love this scale. It's 3 items, it's so short, it's really easy to fill out. But the thing I love most about it is that none of the questions that the older adults are answering use the word lonely. The word lonely is very stigmatized. It's a stigmatized word, it's a stigmatized emotion. People don't like admitting or talking about how they feel lonely or how they're experiencing loneliness. And so I find questions like, are you lonely, or how often do you experience loneliness, are really difficult for people to answer. But this questionnaire gets at the experiences of loneliness. So how often do you feel that you lack companionship? How often do you feel left out? How often do you feel isolated from others? And so I like it because it's talking about loneliness, it's getting at loneliness, but without that stigmatizing language that comes with it. So it's been really well received from the older people that I have worked with who have filled it out. So now I want to know what we are doing to combat loneliness. What do you do at your organization, in your practice, in your work to help promote social connections, to combat isolation and combat loneliness?
And if you don't mind, Christine, I'm going to add another layer to your question. But
Go for it.
In this time of COVID,
yeah,
are we doing things that are a little different? Or maybe we can have a bit of a discussion about it after.
Yeah. So some people talking about specific programs that they're using, art-based programs, music programs, e-visits, like the virtual visits have been a huge thing as a result of COVID. One-on-one visits, so connecting and spending time building a relationship one-on-one with someone. Support groups. I love this one, sharing resources. So if you have an awesome practice to combat isolation or loneliness at your place of work, why not share it with someone else? Pet therapy is another great one. Chit chat, phone calls, garden visits, absolutely. Goal setting, that's another particularly interesting thing is working with people to set goals for their social health and what they want to achieve in their social relationships can be really valuable. So I wanted to highlight a couple of different things in terms of how the world is combating loneliness. So the first that I wanted to really highlight is this awesome work that's happening in the UK. They've really been sort of global leaders in this tackling isolation and loneliness. So first, they actually appointed a minister for loneliness. So they have a government person whose sole role is to help their citizens feel less lonely. And I think that's such a great thing to see, that at a government level, from a policy perspective, that loneliness is up there at the forefront with other key issues that impact residents. The next thing that the UK has done really well with is this campaign to end loneliness, connections, and older age. It's been around for a couple of years now, and they've really done a great job at teaching the public about loneliness, teaching them what loneliness might look like and how to recognize signs, to breaking down stigma associated with experiencing loneliness, and promoting different policies and programs that can be used to support social health of older people in the UK. I highly recommend checking out some of their resources if you're curious to see what they've been doing. The next thing that I want to talk about is social prescribing. This is sort of a new and emerging thing that we're seeing in the healthcare sector, and it's when a client goes and meets with their healthcare provider. It could be a physician, a nurse practitioner, but it could also be a social worker, an occupational therapist, a recreation therapist, a healthcare provider, who will identify some aspects of their social health that could maybe be enhanced or better supported. They'll write a prescription for it and then refer them to a social prescribing navigator who helps that person get connected to social resources in the community that could enhance their social health. And then the idea is that they go and participate in those activities. And so I think this is great for two reasons. The first, obviously, being that it's helping directly connect people to social opportunities in their community. But the second thing that I think is so great about this is that it's really encouraging healthcare providers to consider and make social health a part of their standard of care, a part of their care planning, a part of their assessment. It's encouraging and prompting practitioners to ask about their social health just as they would ask about their smoking habits, their exercise habits, their eating habits. So it's making social health sort of the forefront, and one of the key things that we're talking about, starting to normalize and make this a standard part of our practice and a standard part of our care support when we're working with older people. The picture on the right is an example of a social prescription pad that one community health center has been using to help prompt and guide the conversations between the provider and the client around their social contacts and their social experiences related to isolation and loneliness. Another opportunity in the community that I want to highlight here is the Student Senior Isolation Prevention Partnership, SIP. So this is a volunteer-based program that it started actually at the University of Toronto with health professional students, so students in medicine, OT, PT, social work, nursing. At the University of Toronto, they have over 270 student volunteers who participate in this program. And how it works is healthcare providers can make referrals. If you have a vulnerable older client, you can make a referral to this program, and they carry out social comfort and connection phone calls to help reduce isolation. And during COVID, that's been one of their main things, is to do friendly phone calls to help reduce that isolation and provide meaningful connections and contacts to isolated seniors in the community. This program has spread to other universities and other communities. So McMaster has one at both the Hamilton, Kitchener, and Niagara campuses. Western has one in London. Kingston, Queen's University has one in Kingston, and the University of Ottawa has one in Ottawa. So if you have an older adult in your practice who is more vulnerable and has access to a telephone and is able to carry out conversations on the telephone, this is perhaps a service that might be of interest to you. There's been a lot of research on different interventions in long-term care settings that have been used to combat loneliness. Simple things like video conferences and other social facilitation activities, all the way through to pet therapy, laughter therapy, physical exercise programs, as well as other general activities that might happen in a long-term care setting. There were a couple of systematic reviews that were published in 2019 that showed that most of these interventions are actually quite effective at reducing loneliness or improving other social outcomes that they were interested in, like improving quality of life or reducing symptoms of depression. One of the systematic reviews concluded that the most effective therapies for reducing loneliness specifically were reminiscence therapy, laughter therapy, and horticultural therapy. And the slide I want to end with here is the virtual visits. And I'm sure this is something that you are all becoming very intimately familiar with, very confident doing, as this is how most long-term care homes and other communal living settings have pivoted in order to help make sure that residents are remaining connected to their families, even though families are no longer, there were restrictions on who was allowed to come into the homes during the pandemic. So I'm sure people have ironed out a lot of kinks that they maybe experienced offering virtual visits over the course of the last several months, but the Ontario Association of Resident Councils has a toolkit that they put out that helps go through some of the policies and practices around hosting virtual visits in your home, around troubleshooting some common problems that people are experiencing. And I think this is also a great thing for us to talk about in terms of how effective you have found virtual visits being in terms of combating isolation and loneliness and helping residents stay connected to their families. And that was it for me. Thank you so much.